Hello everyone, I'm Dr. Vamsi Krishna, consultant neonatologist and pediatrician at Cuddles, Kondapur. Today we'll be discussing they are very easy to practice. However, practices will definitely lead to a positive outcome for and low birth weight infants, and also it will be very much beneficial to the mothers who are carrying these babies. So that topics briefly. So the overview of my presentation is today we'll discuss about what is skin to skin contact, what are the benefits for mother and the baby dad, what is kangaroo mother care and benefits, and we'll discuss briefly about the recent advances that happened in the kangaroo mother care. So suppose we might have faced this situation many times. So a term 3 kg baby was being born to a primary gravida mother by normal vaginal delivery, and baby has cried immediately. An upper scores of around 8 and 9. So what is the next step that you are usually doing as per the neonatal registration program iteration? So as we know that any baby who's born a term gestation with a good tone and who's breathing or crying, obviously will allow the baby to stay with the mother and for the routine care with an ongoing evaluation. So one of the important component of the routine care is providing warmth to the baby, and this can be provided by doing the skin to skin contact immediately. So for all the babies who are stable enough, the NRP edition suggests to do a skin to skin contact as it is shown to have a better benefits for the babies and the mother. So now we'll discuss what is skin to skin contact and what are the advantages. So what is skin to skin contact? So the skin to skin contact is a placing a newly born stable baby after drying immediately on the mother's chest in between her breasts, and both of them should be covered with a warm dry blanket. So these are practiced meticulously because if you don't put a warm blanket, it can lead to the evaporative water losses from the back surface of the baby, and that can lead to the hypothermia. And this skin to skin contact should be initiated immediately after birth or as early as possible, and the contact should maintain for a minimum duration of 1 hour. We need to place a stable dry baby over the mother's chest in between the breast and should be covered with a warm blanket as soon as possible, and with the minimum duration of 1 hour is called as a skin to skin contact. So this skin to skin contact initiates a strong instinctive behaviors in both the baby and the mother. In the mother, there will be a surge of hormones which leads to a smell, stroke, and engage of the mother with her baby. Also, the skin to skin contact elicits in the newborn an internal process which lead to 9 instinctive stages, which are the birth cry, relaxation, awakening, activity, rest, crawling, familiarization, and sucking, and finally sleeping. So by going through these 9 instinctive stages, the baby will start suckle by about 1 hour of age, and which leads to an early establishment of the breast to breast feeding in the baby and the mother. For these 9 instinctive stages. So as you can see in the picture, so the first stage is the crying of the baby. As soon as the baby is born and the baby is doing the skin to skin contact, only the baby has been crying unstable. So immediately the first step will be the cry of the baby. Then we keep the mother chest in between her breast. Then the baby will bit a bit of relaxation as his baby is in contact with the mother, and baby will sleep quietly. Then slowly the baby will awaken, where the baby eyes will be opened up, and the baby slightly to move his or her head, but without a major limb movements. And the fourth stage is activity. Here you can see that baby start moving his limbs. The baby is moving his head, eyes are open, and the baby slowly start becoming to move towards the breast. Intermittent at any point after the birth or after the relaxation, after the activity, the baby can take a pause. This is called the resting stage. Finally, the baby start crawling towards the breast. So this is also called as breast crawl. So to facilitate these things, so majority of the centers are advised that we should not clear the amniotic fluid of the hands of the baby. So that will allow the baby to crawl over the mother chest towards the breast. So once the baby reaches the mother's breast, then baby will get familiarized to the breast. Baby will identify the baby will feel more better as soon as it reaches the breast. Then slowly the baby start opening his mouth and try to suck the breast and nipple. So there will be a good transfer of the colostrum, which is the first vaccination for the baby from the mother. Then after that, after taking it, the baby starts sleeping. So in this way, the baby can be started on the breastfeed, and which can lead to an early successful establishment of the breastfeeding. So by doing the skin to skin contact, so what are all the benefits that baby can have? In a simple way, the Bistro et al. In 2016, they have shown that babies who have been started, 2003, babies have been started on skin to skin contact have a better physiological function stability, which means that they can regulate the temperature very well. The heart rate regulation is good. The respiration of the baby will be more stable and regular way, and they can have a good gastrointestinal adaptation so that they can better have a feed tolerance. So by doing this, the babies will be more physiologically stable. And also, Lamy et al. In 2015 has done a study where they found that by doing the skin to skin contact, they're able to decolonize the baby's skin with the MRSC and MRSC with a significant statistically around more than 2.27 risk ratio. Also, by doing this skin to skin contact, many studies have identified that the baby's skin will be colonized with the non-pathogenic bacteria that is present on the mother. Thereby, they will fight with the bacteria that's coming after the delivery, which are the pathogenic bacteria. They will compete with them for their survival. And so they don't allow those bacteria get colonization of the skin of the baby. However, these colonized mother's friendly bacteria will not cause any infection because the mother will produce antibodies to these them in their milk, which will be transferred to the baby during the colostrum feeding and also subsequently. In this way, the baby's infection from these baby friendly bacteria will not happen, and the new infection will not occur to the baby because of their fight with them. So overall, these things, the baby will have a decreased chance of the infection. So the Cochrane evidence by the Moore et al. In 2016, where they found the difference of the to the baby by doing the skin to skin contact, they found that the breastfeeding rates were significantly higher, around by 26% if you do the skin to skin contact. And the babies who have been skin to skin contact have a higher script score, with the stability for the cardiorespiratory score during the first 6 hours post birth. And the baby's axillary temperature are higher at around 90 minutes to 1 and 2.5 hours of life. And the blood glucose levels were higher around 1.5 hours of life. So overall, the babies have better breastfeeding chances, better physiological stability, better axillary temperature, and better glucose levels if you do the skin to skin contact immediately after the birth. So not only to the babies, there are a significant advantage to the mothers also by doing the skin to skin contact. When you place the baby over the mother by the skin to skin contact, there will be a surge of the oxytocin levels in the mother. So these oxytocin level will lead to the better contraction of the placenta. So which helps in the earlier expulsion of the placenta, thereby on more uterine contraction, which actually reduce the postpartum bleeding and the postpartum hemorrhage. So overall, the mother's stability will be more. And we have seen that the breastfeeding rates were a bit significantly higher by doing the skin to skin contact. And the mother can self-sustain this breastfeeding rates. And all this can lead to the lower maternal stress levels in the mother. So we can have a better mother and infant bonding. So ultimate, our thing is not only the benefit is for the babies, the benefit is also for the mothers. That's why we always recommend the skin to skin contact to be given for all the babies who are stable at the time of the birth. Sometimes we get confused. That is, skin to skin contact and the kangaroo mother care are same. Clear, the skin to skin contact and the kangaroo mother cares are not exactly the same. So there is a lot of difference between the plain skin to skin contact and the kangaroo mother care. So what is kangaroo mother care? Before that, we know that nearly around 20 million infants who are born at less than 2.5 kgs every year over the world. And significant proportion, even 96% of them are being born in the developing countries like us. As we know, these babies, either the premature or small for gestation babies, or the increased risk for early growth retardation. As their immunity is less, they are more prone for the infectious diseases. They have more chances for the developmental delay and even the death during the infancy and the childhood. So in these babies, the conventional neonatal care is a bit expensive as they need high quality equipment, high skilled personnel, and they need a permanent logistic support. All this may not be that great cost effective in order to provide the care. Because of this, a majority of the babies may not receive the high quality and high costly care, so they are suffering. So that's why the concept of the kangaroo mother care has been evolved. So I've seen the Dr. Edgar Ray of Instituto Maternal Infantil Center in Bogota, Colombia, South America. So they want the babies to be cared well, even in the under-resourced settings, in a better ways and in a cost-effective ways, more better or equally efficacious to the conventional routine neonatal care. So they want to cater more number of the underprivileged babies who are definitely in need for a better medical services. So where they found the concept of the KMC has occurred. So the history in 1976, Peter Charter of Sweden has advised for the early contact with the mother and the baby at the birth. However, they didn't label any term. In 1978 to 1917, Thompson et al. Has proposed a term of the skin-to-skin contact for the first time. In 1978, Dr. Edgar Ray of Bogota, so they tried to develop a method where it can alleviate in the resource-limited settings where there is a definite shortage of the caregivers. In 1981, both the Dr. Edgar Ray and Dr. Mantes their first result in Spanish, and they used the term KMC, Kangaroo Mother Care. In 1996, in Italy, the World Health Organization defined the term Kangaroo Mother Care broadly. So in this way, the KMC has evolved from 1976 from a better skin-to-skin contact in 1996, where the WHO organization has defined what is Kangaroo Mother Care. Coming to India, when this Kangaroo Mother Care is being practiced in the Western world, so some of the interested pediatricians in 1995 from the various centers like KMC, Mumbai, Chandigarh, Delhi, Ahmedabad, Rajasthan, Chennai, Lucknow, and West Bengal have gone to there to understand what is this KMC and how do we do this KMC and how can we utilize this practice in our setting so that we'll have a better outcomes. In 2001, Ramanathan et al. In the Indian Journal has first published regarding the KMC in the VLBW infants. In 2008, a network of 5 centers have been developed where they want to initiate the KMC in their hospitals in a better way. And in 2008, there's a first important randomized control trial has been published based on the KMC importance in the low birth weight infants by Dr. Suman et al. From Mumbai. In 2012, an international conference on KMC was organized for the first time in Ahmedabad. From then, the yearly KMC conference has been conducted in different parts of the India. In 2015, the KMC Foundation was formed. In 2016, the guidelines for the KMC has been developed by the government of India. So nowadays, in the majority of the centers who cater for the low birth weight, majority of the areas, the KMC is being practiced as a norm for all the low birth weight care as soon as they become stable. So what is this KMC? Why is it so important? So KMC is early, prolonged, and a continuous skin-to-skin contact between the mother or any other caregivers with a low birth weight. So here, compared to the routine skin-to-skin contact that has been advised at the birth, here the skin-to-skin contact is prolonged and is a continuous skin-to-skin contact rather than a short-term contact at the birth. So in this way, it is different. Also, this KMC, Kangaroo Mother Care, where the skin-to-skin contact is only one of the component, is not the only thing of Kangaroo Mother Care. So by doing this, we can provide the babies the need for the warmth, breastfeeding. We can protect the baby from the infection, along with the providence of the multimodal stimulation, safety, and the love. So this is the Kangaroo Mother Care. And why is it called a Kangaroo Mother Care? So all of us know that the baby kangaroo, which is called as joy, are very prematurely and very small in size. So the mother kangaroo has a pouch where the baby joy is kept in his pouch, and it provides warmth, safety, and a constant supply of the food to the soil. So in the same way, that Ryan team thought that whether we can use these kinds of the concept in the immature low birth weight babies, where this same method can provide warmth, safety, and a constant supply of the food to the mother. So in this way, the Kangaroo Mother Care concept has been developed. So there are 3 important components in the Kangaroo Mother Care. As you can see, one is a kangaroo position, the kangaroo nutrition, and the kangaroo discharge and the follow-up. Each component in detail. So before starting the KMC, we need to do some basic preparation. We need to do the counseling sessions for the mother and the family member, where we actually demonstrate the procedure. So they should be familiarized. What is kangaroo mother care? How do you want to do the kangaroo mother care? Sometimes we may be very different that we are doing something very, very different. But it's very important and a simple process that can be done by every mother who is there. So we'll demonstrate the kangaroo mother care by taking a baby or any other baby model or the chest, and we can demonstrate the procedure, which is very simple. We need to counsel the parents of the baby and also the family members of the baby, because this is very important, as once the mother is getting discharged from the hospital and going into the home, family support is a paramount important. And we need to develop a KMC support group where they support the mother to have a continuous KMC both in the hospital and also outside the hospital. And what kind of the clothing that is required for the mother to do the KMC? So we just require a front open light dress that can be worn as per the local culture. So there is nothing a great kind of a clothing is required for the mother. And for a baby's point of view, the baby should have a cap so that it prevent the heat loss from the baby head. Baby should have a socks, baby should have a glove, baby should have a nappy, and baby's front open sleeveless shirt or jhabla can be there so that the baby and the mother should be open from front to front and they can have a good skin to skin contact. So nowadays, majority of the places, the cloth, the provision of the kangaroo mother care, a different kind of a commercial and locally made KMC bags have been there. So one can use if it is feasible and available. Otherwise, we can do by just having the baby in a KMC position with this kind of a cloth. When come to the component, the first component is kangaroo position, which is the skin to skin contact. And you can see where the babies are being placed between the mother's breast in an upright position similar to skin contact. And the baby's head should be turned to one side and they should be slightly extended so that the baby's airway should be maintained. As we know that the premature babies, the neck is more flexible and more less controlled. So the babies can have abnormal extension or abnormal flexion that can obstruct the airway. So in this way, we need to have this kind of position for a proper position of the airway. The baby's hips are abducted in a fox position so that the baby's abdomen and the chest can be in contact with the mother. The arm should be flexed. That can lead to a kind of relaxation for the baby. And both the baby's abdomen and the should be present at the mother's epigastrium so that the mother's breathing efforts will stimulate the baby. That's why it can prevent the apnea. And we can support the baby's bottom with the hand, or as I've told, there are certain bags that has been developed where they can support the baby's bottom so that they can prevent the accidental fall of the babies. However, it is not necessary for all the babies to have a KMC bag. It can be used if you have an availability and if it's feasible to you. Otherwise, you can use a proper hand, and sometimes we can just wrap the baby's bottom to the abdomen of the mother so it can prevent the fall of the baby. The one of the most important thing is the baby's chest should be exposed completely, and we should not wear any cloth, even the light cloth over the baby's chest, which definitely prevent the skin to skin contact. And majority of the baby's body should be in contact with the mother's chest and the abdomen. Next come to the kangaroo nutrition. The kangaroo will provide their premature babies with her own breast milk. So in this way, the providing the mother's own milk to the baby is one of the paramount important in doing the kangaroo mother care. So this is called the kangaroo nutrition. So whenever there is any chances, like in more than 1.8 kg babies, more than 34 weeks, where we have developed suck and swallow is good, we can directly ask the mother to breastfeed the babies. If the babies are born less than 1.8 kgs, if they're born less than 34 weeks, and the babies where they are not developed suck and swallow coordination well, in this kind of the babies, the mother can express her own milk, and this can be given with palada or with the spoon. So that in this way, only the mother's milk can be given to the baby, which can prevent any feed intolerance infection in the baby. This is called as the kangaroo nutrition. And next is a KMC discharge, the third component. So when we are giving the skin to skin contact and we are giving the mother's own milk, the babies will feed well and there won't be any evidence of infection. By doing this, the babies will gain a better weight gain of around 15 to 20 gram per kg per day. This is an expected weight gain in a babies who are being on mother's milk and doing skin to skin contact. And another important thing is baby should maintain their own body temperature in the room temperature with just a proper covering without any additional heat source. And the mother should be confident enough on how to providing the kangaroo mother care, how to take care of this low birth weight, how to identify the danger signs, how to keep her baby warm, keep her baby free from infection, keep her baby clean, and she should be trained enough to identify any danger signs that can occur. So when there's all the things have been satisfied, we can have an early discharge. We don't need to we don't need to make them wait till the baby reaches a normal term gestation or around a normal birth weight. We can discharge the mothers and the baby dad a bit early when these criteria have been met. As we are discharging early, we need to have a strong follow-up and a proper follow-up where we at least expect to visit us immediately around 40 to 72 hours after the discharge, and we need to monitor them once or twice a week till they reach around 37 to 40 weeks or 2.5 to 3 kg. Once they have reached the term gestation or a normal birth weight, they can have a once or twice monthly visit till 3 months, and then they can have a 1 or 2 monthly visit during the first year of life. However, this is for the babies who are growing well and who are not having any major signs and symptoms. If any babies who are not gaining weight or the babies who are having any major other problems, we need to have more frequent visit to support the mother. So the discharge and the follow are the more important, where we need to have a structured program follow-up clinics where we can identify these babies growing out of the deviation from their expected thing, and we can teach the mother or we can train them in a better way so that they can continue to grow well in their homes by doing the KMC. So all the units who are doing the KMC and discharging follow-up are nowadays are having a well-structured follow-ups where the multiple things are compared to the growth, the nutrition, other supplements, and other screenings of the babies have been planned. The KMCs, the sensation that the wire, the brain are actually get stimulated. As we can see that when the baby is kept on the skin-to-skin contact and the baby is being fed, so the baby can have a direct eye-to-eye contact with the mother. So the vision sensation has changed. The babies can be very close to the mother. So the smell from the breast milk can satisfy the sensation of the smell. The mother's own milk satisfy the taste. As the baby's hands have been flexed and are touching the mother's skin, so the touch sensations is being satisfied. The baby also have a skin-to-skin contact with the mother of the whole body. The warm hands that is surrounding the baby all lead to the touch, and also the movement from the mom all satisfy the touch sensation of the babies. Maybe close to the mother, the babies can hear the heart rate of the mother and also the voices of the mothers, which will satisfy the hearing sensation of the baby. So by doing all these things, we can have all the sensation of the babies can be satisfied. So that's where the kangaroo mother care is one of the most important for the babies. So by doing the kangaroo mother care, so we can provide a definitive warmth 24 hours, even without using an incubator or the radiant warmer, so that the babies can be kept along with the mother for a majority of the time. Whereas we have seen the multimodal stimulation is happening, and as we have kept the babies on the mother, and there is a transfer of the mother-friendly bacteria to the baby, and also as the babies are not there on the crib or the cradle, the radiant warmer, so the chances of the hospital-acquired infections are significantly less. They have a better physiological stability. That the rates of the apneas are come down, so the oxygen requirement has decreased because the mother breathing efforts will stimulate the baby and baby will not go into the apnea. So by doing all these things, the babies will have a better IQ, better alertness, and a very prolonged quiet sleep. All of these things can lead to an early growth spurt in the baby. So the babies will grow a bit better compared to the babies who have not been on the KMC. Benefits to the babies. There are better benefits to the mother. So mother will be involved in the caring of her baby by providing the skin-to-skin contact, by milk and taking care of the baby. So she will be self-confident. There will be more chance of a successful breastfeeding, better bonding with the baby. So there is a more self-satisfaction. All this will lead to the early discharge. So there's a reduced amount of the hospital stay, and they have a significant impact on the economical background also. So as the babies are getting discharged, so the economical burden on the parents and even on the healthcare facilities, there is a significant decrease. So in this phase, the benefits are not only to the babies, and it can be translated to the mothers and even to the economical benefits of them. So they by decreasing the economical burden on the families and the healthcare facilities. So not only the theory, so the studies, many studies have been done on the importance of the KMC and their outcomes. So we have a Cochrane by the Conde Aguirre et al. In 2016, where they found that a significant reduction of 40% reduction in the mortality and 65% reduction in the hospital-acquired infection and sepsis. And the hypothermia rates are decreased by 72%. So these are very, very significant numbers. So that's why I strongly propose to do the KMC to have the reduction in the mortality, hypothermia, and the infection. And also the babies will gain a better weight gain in the form of around 4 grams per day can extra weight gain can happen when the babies who do the KMC. And even the length gain will be around 0.2 centimeters per week extra, and head circumference gain will be 0.14 centimeters per week extra. These are the things that are extra when compared to the conventional care weight gain. So all these can lead to the better early discharge and decrease in the hospital stay. Under the follow-up, they found that the exclusive breastfeeding rates at the discharge or the term gestation are very high, and even the breastfeeding rates at any point after the discharge are also definitely high compared to the babies who are just doing the conventional care. Mortality and hospital stay. The KMC can also decrease the pain sensation to the babies. So the KMC can actually decrease the crying duration. It improves the pain scores, and it also decreases the stress. However, it should be at least from 10 to 15 minutes prior to the painful procedure. We can't keep the baby on KMC and do the painful procedure. We need to keep the baby at least some time before the initiation of the painful procedure. Then it can decrease the crying time and the pain scores. We don't know what is the mechanism, how the KMC will decrease the pain. Maybe the better ability of the newborn to self-regulate lead to the better, less stress, and even to the hearing of the maternal heartbeat can lead to the decrease in the pain sensation in the baby. But definitely by doing the KMC, we can decrease the pain scores and decrease the stress in the baby. So a steady randomized control trial done in Mumbai by Nanavati et al., where they compared kangaroo mother care with the excess breast milk to see the effect on the pain when they want removing adhesive tapes in a very low birth weight infants. We know that express breast milk, when we provide extra breast milk or some sucrose to the babies who are being exposed to painful procedure, because of these things, we can definitely, there is a decrease in the pain levels. However, they want to compare whether this efficacies in doing the express breast milk administration in decreasing the pain scores, and they found that the painful procedures were significantly low in the case of the babies who have been exposed to the KMC, on par with the babies who have been the express breast milk. So we can actually try the KMCs to the babies where we are not able to give the milk, so that we can do the painful procedures by providing the KMC, so we can have a decrease in the pain scores in the baby. Even the Cochrane by the Johnston et al., which was published in 2013, where they found that skin-to-skin care, which is a part of the KMC, will definitely reduce the procedural pain in the neonates. So not only that, now we have seen all the short-term effects in the form of discharge, decrease in the pain, better breastfeeding rates. So will these effects will translated in the long-term way? So in order to study this, Charpak et al. In 2017, where they have a 20-year follow-up of the kangaroo mother care babies and the additional care babies, and they published their results in 2017. So they found that the effect of the KMCs at 1 year on the IQs of the baby and the conditions of their home environment were still persisting even at the 20 years in these most fragile individuals. They found that the KMC parents were more protective and nurturing their kids. This led to a reduced school absenteeism in the babies. These babies have a reduced hyperactivity, they have reduced aggressiveness, and they have reduced externalization and more decrease in the social deviant conduct of these young adults. And when they done the neuroimaging, they found that the large volume of the left caudate nucleus is seen in the KMC babies. So in this way, we could able to understand that the effects of the KMC are not only beneficial in the short term to the babies and the mother, they're sustained in the long term, even at the 20 years of life. So that's why we strongly advise the KMC for these suitable patients. The KMC should be done. Traditionally, the KMC has been advised to the babies who are born at more than 1.8 kilograms to start as at birth. For babies who are 1.2 to 1.8 kilograms, they should be KMC should be started as soon as the babies are hemodynamically stable. So these babies usually may have some kind of hemodynamical instability, might have respiratory distress. So we can start as the babies are hemodynamically stable. But less than 200 grams, stability of the baby is the must. Only the baby are stabilized, then only we can start the KMC. Now, these are the traditional things, and we'll discuss more recent things where we have the evidence that we can start the KMC as early as possible. Not only the baby, the mother should be eligible in the form of she should be counseled enough so that she should be knowing the benefits of the KMC and she should be willing enough to do the KMC, and her health and the general condition and the nutrition of the mother should be well, then only she can continue the KMC. She should maintain a proper hygiene, otherwise it can lead to more infection if the mother is not practicing the hygiene. As long the mother is practicing the hygiene, it definitely lead to a better benefit in the baby and decrease the infection, doesn't increase the infection at any point of time. And she should have a support to family and a support to community, so that once the KMC has been established in the hospital, she can continue the KMC in their homes. Otherwise, the KMC may not be possible to her if she need to do the domestical needs for the family. So in this aspect, the mother need a strong support from her family and the community to continue the KMC even at the home. To implementation of the KMC in the units, we need a sisters who have been trained enough. We need a doctors and other staffs where they can support the KMC. We need to provide the educational materials in the form of a printed sheets, posters. We used to even project the videos of the mothers who have been doing the KMCs. We need to have a videos on their outcomes and the mothers expressing their confidence and the benefits on the use of the KMCs. And regarding the equipment, we just need a semi-reclining easy chairs, and we can have a beds where we can adjust the backrest. So these are the minimum thing that we need to establish a KMC in the hospital. So this is very easy, and we don't require any hi-fi environment, hi-fi equipment for the implementation of the KMC. And by doing this simple thing, which is very important, we can have a very great outcome with KMC now. And during the KMC, we should monitor the babies in the form of the baby's neck should be maintained in a neutral position. We need to see how the baby is breathing. Majority of the times, the mother respiratory efforts will stimulate the baby, but still we need to monitor the breathing of the baby. In the centers where are feasible in the initial period of time, we can have a pulse oximeter attached to the babies. And we need to monitor the color of the baby, whether the color of the baby is pink or baby is becoming blue and going to the cyanosis. And the temperature of the baby should need to be monitored and maintained as long as the baby is in contact, skin to skin contact with the mother, and the back of the baby should be covered enough to prevent any other kind of heat loss. The baby temperature will be maintained. Even the mother temperature will increase by 1 degree centigrade to maintain the norm, to maintain the temperature of the baby when doing the kangaroo mother care and skin to skin contact. So now we understand KMC is important. So we can, and also we know the eligible criteria. So now we'll get a doubt whether we can do the KMC only when the babies are stable, so that we can have a continuous KMC. So can't we do any other kind of KMC? Continuous KMC is available? Yes, we can do. The continuous KMC is not the only option to get these benefits. Continuous KMC is not the only option. We can practice intermittent KMC when the infants are still in the incubators or when the warm rooms are available. They're not yet completely clinically stable to have a prolonged continuous KMC, like when they're receiving the oxygen therapies, when they're on the respiratory supports, other respiratory support, and also in the areas where we have a small NSUs where we don't have a special rooming in for the babies and mother. In these areas, we can practice the intermittent KMC. So World Health Organization recommends that whenever there's a continuous KMC is not possible based upon the baby status, or whenever the any space constraint or the facilities are not available for the continuous KMC, we can use the intermittent KMC better rather than just having the conventional care for a stable newborn baby who are less than 2 kilos. The intermittent KMC actually is a recurrent KMCs, but may not be a prolonged continuous skin-to-skin contact between the mother and infant. And it is a betterly benefit compared to your conventional care. We are not at all giving any KMC. So in a continuous KMC, where the baby is on the skin-to-skin contact for a majority period of time, in intermittent KMC, when the baby is on support or baby is on incubators, where the parents, father or mother or any caregivers can go and provide intermittently the KMC, so that the KMC is initiated much earlier before the babies have any other complications. But even though intermittent KMC looks good, the evidence for the mortality is not conclusive. But there is strong evidence that intermittent KMC reduces the risk of hypothermia, severe infection, and the nosocomial infection. So we can do the intermittent KMC multiple times throughout the day. However, the time period can vary from minutes to hours at a time. But we strongly suggest to at least do 1 to 2 hours of the intermittent KMC. That will be a bit physiologically suitable for the baby. Because if you do for a short period of time, if less than 1 hour, so we need to remove the baby from the radiant warmer or incubator, need to open up the baby, remove the shirt, and then we are putting the baby on the mother, In this time, and when we are stopping the KMC, again we need to remove the baby from skin to skin contact from the mother, need to wear the cloths and adjust the babies in the incubator. So these putting and remove from the baby only will consume a significant amount of time. So if you do less than 1 minute, this kind of may not be feasible for the baby, and baby will be more exposed to hypothermia. Also, the babies also have a sleep cycle. So if you have at least some 2 to 3 hours of KMC, minimum 1 to 2 hours of KMC, this can be adjusted with the sleep cycle of the baby. Otherwise, we'll be continuously disturbing the babies and the sleep can be affected. So the duration of the intermittent KMC may be at least for 1 to 2 hours. However, it can be adjusted based upon the infant condition, the sickness of the babies, and the availability of the mother or the caregiver. So by doing the intermittent KMC, we can allow the mother to take part in the care of the baby early. Once as soon as they stabilize, even before the baby's conventional care can be continuous KMC can started, we can ask the mother to start providing the KMC, and by this we can encourage the mother to take part in the management of her baby so that she can feel a bit relaxed, and even the babies feel that they are being in touch with the mother. And similar to this, we don't need any special equipment for starting intermittent KMC. We just want a willing mother, and we need a staff to counsel the mothers and help them in initiating this intermittent KMC in the initial part of time when the babies are not completely stable. So, for the supporting evidence is that study done by the Jayaraman et al. In 2017, where they had done the RCTs and they compared this effect of the intermittent early KMC versus the conventional late KMC when the babies are stabilized on the human feeding in the infants, where they have enrolled 80 neonates and have been two arms. One arm is early intermittent KMC, where they are provided for 4 hours a day, and the late KMC, where they have been started the KMC after 4 days. And compared to the early KMC and the late KMC, they found the human milk feeding, the direct breastfeedings were significantly higher, and they even continued till the discharge of these babies. And also they found that the babies who have been on early KMC has less chances of the apneas and less requirement of the oxygen support. We can see the outcomes. So compared to the late KMC, the early KMC babies have a statistically higher chances of achieving exclusive human milk feeding with a statistically significant p-value of less than 0.001. And the type of milk, we can see that the exclusive human milk were being given for more babies who are in early KMC, because by starting KMC, the mother milk out will be more, and even for the baby, have the better chance of the taking the exclusive human milk. So this lead to a decrease in the formula feeding, and that lead to a better chances of the food tolerance of the baby. So how long we need to do the KMC? As we said, at least a minimum 1 hour to 2 hours should be started initially as a part of intermittent KMC. Then the babies are being stable. We can transit from a conventional care to a longer KMC period, where the babies, rather than keeping on the radiant warmer, the mothers can come participate in the baby's care and they can take the KMC for a longer duration. And once they have been stable enough, with transport on the off respiratory support, off IV fluids, and don't have an apneas, where we transfer the babies to the postnatal ward, where they can do a continuous KMC. Sometimes we have been given for around 18 to 24 hours of KMC given by the parents, may not be a only mother. So the other family members might have been participated. So with this, their support, we can even provide 24 hours of KMC when the weight gain is not appropriate. So once the babies are stable, and even in the home, the babies can be provided continuous KMC for a long duration of time. But we definitely advise at least for a minimum duration of 8 to 12 hours of a day for a KMC will lead to the positive effects in the babies. And we can extend till 18 to 24 hours if the feasibility of the parents and the relatives is there. And we usually advise to discontinue KMC when the babies are reached the term gestation, they reach the 2.5 kg, and we may stop even early when the babies actually feel uncomfortable. We have seen sometimes the mothers are complaining us that we're not able to keep the babies in the KMC because the baby is crying, babies want to come out of it, baby wriggle, and baby even pulls out of the limb. And then we may need to stop the KMC early also. But as long as the babies are comfortable, we can extend till term gestation and we can extend till 2.5 kgs. After that, the babies will be, temperature will be self-regulated. And we can even continue the KMC after giving the baby a bath and even during the cold nights. So where the babies can be kept more warm by doing the kangaroo mother care. So till now we have spoken for the KMCs, their benefits, how to start, when to start, how many days needed, start intermittent KMC and continuous KMC. Then majority of the people will think that, so this KMC is available only in the hospitals, or we can initiate and start the KMCs when the babies are not being hospitalized also. So there comes up the concept of community KMC. So community initiated KMC were thought because even though we are developing, majority of the deliveries are happening in institutions, whether it can be government or private, where a trained doctor has been involved in the management of the delivery. Still, in majority of the areas, the rural areas, when the facilities are not available, significant amount of the low birth weight babies are being born in a small maternity centers or in the homes where the trained boys are still doing the deliveries. So we're not able to initiate the KMCs in these kind of low birth weight babies, and these babies are getting deprived of all the benefit of the KMCs, and they're not being advocated or they're not being counseled for the initiation of the KMC. Even World Health Organization, even though they have stated the kangaroo mother care is a standard norm for the very low birth weight babies, the coverage of the KMC over the last decade is significantly lower, because as we said, some significant proportion of the population in the rural areas and in some low resources areas is very high when the babies are being delivered in the homes and the small maternity states where the babies are not actually initiated in KMC. So then the thought process has been arrived that can we initiate these KMCs at the community level, will lead to any other benefit or not. So there comes a concept of CIKMC, that is community initiated KMC has started. So one of the important study done by Mazumdar et al. In 2019, where they studied the community initiated KMC on the survival of the low birth weight infants. So in Haryana, they enrolled around 15 babies of around 1500 to 2250 grams babies who has been delivered at home, and they have enrolled within the first 72 hours of life if they are not already initiated on the KMC, irrespective of where they have been born. The mothers and the infants in the intervention group were visited to their homes on day 1 to 3 in first 3 days, then at 5 days, 7 days, 10 days, 14 days, 21 and 28 days, and they were being supported to initiate the KMC, which is the skin-to-skin contact and the exclusive breastfeeding. So in the intervention group, they went to the home on first 3 days and 5, 7, 10, 14, 21, 28 days, and they helped their mother to initiate the KMC. And the conventional group where they didn't initiate the KMCs. And between July 30, 2015 to October 31, 2018, they nearly enrolled 8,400, which is a significantly high number, of which 4,480 were assigned to the intervention group where they have been supported to start KMC. And 3,920 babies will be enrolled to the control group where they didn't support for the initiation of the KMC, and they are not just following the conventional care. And they found that the death rate in the first 28 days was decreased by 29%, statistically significant. And the 6 months mortality is also decreased by 24%, is also statistically significant. So with this, they came to conclusion that by doing the community KMC in the home, there is a in the neonatal mortality rate and in the first 6 months mortality rate. So in the low income and the middle income countries, in kangaroo mother care can be incorporated for all the low birth weight infants wherever they are born, whether in the home, whether they can in the hospital, will definitely reduce the neonatal and infant mortality. So in this way, we can see whether in our areas where the babies are being born in small maternity centers or small primary healthcare centers, and even in the hospitals, whenever we get the chance, we need to set up this awareness of increasing the kangaroo mother care and their benefits in these low birth weight babies, so that can definitely decrease the neonatal mortality and 6-month mortality. Under the leadership of the Thanese et al., the same babies who have been enrolled in the community shared KMCs in the Haryana, few of the babies who are in the intervention group, they followed them for the neurodevelopmental outcomes during the infancy. By using the BSID2, they found that the cognitive, language, motor, and the socio-emotional outcomes that are assessed in 6 months and 12 months were not different between the babies who have been in the conventional care and the babies who have been started in the community shared KMC. However, the initial benefits are pretty good. The long-term benefits in their sample size are not different. However, this very small sample size, so we need a long-term follow-ups in a more large proportion of the babies, where we can definitely identify the long-term benefits of the community-initiated KMCs in this kind of population. So then we'll discuss briefly about what is the IKMC. So how does this IKMC concept arrive? So IKMC is immediate KMC. So what happens is, when you have reviewed the literature, 45% of the neonatal deaths were occurring within 24 hours of birth, and nearly 80% are happening during the first week of life. So majority of the deaths are happening in this low birth weight in the premature babies, even before we initiate the KMC. As we usually initiate the KMC based upon our previous eligible criteria guideline, by the time the babies are stable, in less than, especially in less than 0.5 kg on VLW babies, it usually takes around 3 to 10 days for the babies to initiate KMC. But as we see that significant proportion of the neonatal deaths are happened already by the time we initiate the KMC, we are losing so many babies as we are not able to initiate the KMC till we are waiting for the stability of the babies. So here we are losing so many babies before we initiate the KMC, which is definitely having a positive outcomes on their mortalities. So there the concept of the immediate KMC has been arrived. So World Health Organization started this immediate KMC study group where they have done RCTs in multicentral trial where they include the 5 hospitals in Ghana, India, Malawi, Nigeria, and Tunisia. They have enrolled babies of 1000 grams to 1799 grams, and they were assigned randomly to the immediate KMC group where they have started KMC in the first 24 hours of life in respect to the clinical status, and to the control group where they have been started KMC after they are being stabilized with the conventional care, and then they have started KMC. So they found that by doing this kind of immediate KMC within first 24 hours of life, they found a significant decrease in the mortality in the neonatal period by 25%, and especially the mortality decrease in the first 72 hours by the time where we have not started the KMC is around 23%. So in this way, by starting the immediate KMC as soon as the facility is available in first 24 hours will definitely decrease the neonatal mortality, especially the mortality in the first 3 days. And also they found that the maternal satisfaction is better as they've been involved much pretty earlier in the management of the babies and chronic KMC. And there is a decrease in the suspected sepsis in these babies, and the chances of hypothermia are pretty low in the babies who have been started on the immediate KMC. So this the concept of immediate KMC has been arrived. However, we need a proper mother and neonatal ICUs where we can keep the mothers along with the babies, and so that we can start this immediate kind of KMC. So in the future, we can see that more maternal and neonatal ICUs MNCU can develop where we can start this immediate KMC, which will be very beneficial to these preterm babies. Then coming to, there are certain new things that are happening in the skin-to-skin contact and the KMCs. So we'll have a brief discussion on it. So you can see here, we have seen this baby. This is the routine position of the KMC. Mother is holding her baby in a vertical position over her chest. So here we can see that baby is not kept vertically, baby is slightly diagonally placed. So what is this position? So this position is called, so here also we can see the mother is kept in the conventionally keeping the vertical position. Here the mother is keeping her baby diagonally in a diagonal state. So this is called as SDF. It is SDF is supported diagonal flexion. So supported diagonal flexion is a new kind of position. So people have tried to evaluate its benefit. So the Bull et al. Have done a study in 2016. So where they took 15 mothers who was given the babies of around 26 to 32 weeks of gestation, and they were assigned randomly to the vertical positioning, which is a conventional positioning, where they have enrolled on 7 babies and 8 babies in this new position of supported diagonal flexion. And they found that by doing the supported diagonal flexion compared to the vertical position, the babies on the SDF has led to fewer disorganized gestures. There are few negative vocalizations and drowsiness, and they have more deep sleep in the babies on the SDF position. Also in SDF, where the babies are diagonally kept, so they can have a better eye-to-eye contact in the mother. So here we can see that babies have better eye-to contact as in a diagonal way. The mother and the baby's eye-to contact is better in the babies or in SDF can compare to the conventional vertical position. So there's a better mother and infant eye-to-eye contact. There's a maternal vocalizations are better. The smiles and caressing of them are better. However, these may not lead to a significant levels statistically because the sample size is a bit low. However, with this study, we can know that SDF is a new positioning where we can have a better results compared to your vertical routine conventional position. And they found that the score for the risk for the postnatal depression in the mothers has decreased significantly between the first and the last station of the STF group compared to the vertical position group. So overall, the conclusions are the immediate benefits on the mother and the infant directed communicative behaviors are very good. And this SDF is an innovative but an inexpensive and easy to use technique in the daily practices by all healthcare professionals working in the NSUs. And the benefits and the safety of the Kangaroo SDF position, the larger groups of the preterms are required, as we have seen that the population size of these study is just 15. So when you have a large population, we can have a better statistical significant outcomes where we can do this STF position along with the vertical position, which may lead to better benefits in the baby. And there is a concept of Kangaroo. So previously, we know that in Western world, we have a doula, is a person who is trained to advise the mother, inform and offer the emotional, physical comfort to the mother before the delivery, during the delivery, even after the birth of the delivery. So her main role is to support the mother and provide her comfort. So this doula word came from a Greek doule, the meaning of which is actually a female helper or the maid servant. The doula is the focus of the doula is on the mother needs during the labor and the birth, where she provided comfort and support to the mother. A Kangarola also do this, but also she advocates for the baby during the labor, birth, and the first 1,000 minutes of life, where she will support the mother for the providers of the skin-to-skin contact and kangaroo mother care. So her additional role along with the routine doula is she will support the baby for the kangaroo mother care. So this way she is called as kangaroo and doula, kangaroo doula. So where the mother or the father's baby, so they should develop a skin-to-skin contact with the mother body so that the babies will have warmth, better feeding, sleeping, and emotional connection will be developed. So the first day is when the huge amount of the support is needed. If you are able to support in the first day, then you can have a better and a bright and noisy adaptation will be there once you are supporting this first day. So this Kangarola predominantly will help the mother in the immediate postpartum period to support them emotionally and also the providing of the skin-to-skin contact. In routine care of the preterm, so majority of the studies has been done for the kind of stress, kind of the benefits to the babies and the mother. The fathers, even though play a major role in management of the babies, taking care of the babies emotionally, socially, financially. So the fathers have been not that recognition has been given to the fathers. So even the fathers have a significant amount of stress, both emotionally, socially, and economically. So they can also need to be supported in a better way. So that their stress levels will become low. So what we have done is in our majority of the centers, so where the kangaroo mother care along with kangaroo mother care, we used to allow the fathers to provide the kangaroo father care. So we, similar to mothers, we used to have a specific time period where the fathers will be allowed to provide the kangaroo mother care. We call as a kangaroo father care. So the benefits translate to the babies are similar: better weight gain, better temperature management. So we have want to study how this effect will be there on the stress levels of the father. So study done by Nanavati et al. Where in KM Mumbai, where they want to study the stress levels of 30 fathers based on the parental stress scale. So where they found that stress levels were significantly lower after the fathers have done the KFC. So in this way, they found that fathers of the preterm infants who are admitted in NSU, they found that the stress levels are significantly high that can affect the mental health. But after doing the KFC, the scores were statistically significantly decreased. So also a study done similar in Mumbai, where they want to study in 30 fathers of the VLBW infant in a tertiary care. They want to study how this kangaroo father care is affecting the father and infant bonding by administering a PBQ scores before and after 7 days of successive KFCs. So they found that by doing the kangaroo father care, the infant and the father bonding are significantly higher after the 7 days of KFC, and also the baby and the fathers have helped us. The KFC has helped the father in improving their impaired bonding, anger, and the anxiety. So in this way, the kangaroo father care can reduce not only provide the benefits that have been similar to the kangaroo mother care, the father care will definitely lead to decrease in the stress levels and more father and infant bonding will happen if you allow the KFCs. So that's why we need to even allow the fathers to the NSUs as feasible so that they can effectively participate in the management of their babies and they can do the kangaroo father care and they can even continue doing in the home so that the mother will get some time in carrying her domestic needs and further taking rest of the baby, and also the stress levels in the fathers will be decreased. So we strongly recommend for the doing the kangaroo father care in your units and even in the family, and we suggest you to provide the facilities for doing the kangaroo father care. So with this I conclude my topic. So I thank you for the patient listening.